Today we talk about two things that may look the same, but definitely aren't the same: Clomid and Femara.
I'm Dr. Mark Amols, and this is Taco Bout Fertility Tuesday.
Clomid and Femara, also known as clomiphene citrate and letrozole. Both are pills, both used for ovulation. But they're often mentioned in the same breath, and many people assume that they do the exact same thing. But the truth is, they take very different routes to get your ovaries to do the same job. And just when you think you figured it out, I'm going to throw in a third player, the injectables, also known as gonadotropins. So by the end of this episode, you're going to know why your doctor picked one over the other, why higher doses don't always work better, and why sometimes doing more isn't really helping at all. Now, all three of these medications share the same goal, and that is to help your body release a mature egg or sometimes multiple eggs. But as I mentioned before, they go about it in different ways. We've got Clomid and Femara, which are oral medications that are going to trick the brain into releasing more hormones. And then you get the gonadotropins. These are the injectables that skip the brain entirely and go straight to the ovaries, mimicking the exact same hormones that come from the pituitary. Now, I say mimicking, I'm saying they're actually bioidentical, not the actual hormone. So Clomid and Femara are the indirect way, and gonadotropins is the direct way to stimulate the ovaries. Now, I'm sure it's obvious that gonadotropins were made to stimulate the ovaries. That's why they were made that way. And there's been different versions. Some are from humans, which are from menopausal women who release FSH, like Menopur. And then some are made as bioidentical, where they actually go and generate the hormone. And that's what a lot of people take. But what about Clomid and Femara? Well, were those made for fertility? Well, Clomid was actually created in 1950 as a birth control pill. They thought that maybe the estrogen blocker would then stop ovulation, but to their surprise, it did the exact opposite. Women started ovulating. So by 1967, Clomid was officially approved to treat infertility. It was kind of the world's first oops, but in a good way. Now, Femara, also known as letrozole, came along much later, back in the 1990s, a long time ago. Its original purpose was breast cancer treatment. It worked by lowering the estrogen levels, which helped slow estrogen-sensitive tumor growth. Then fertility specialists started realizing that the short drop in estrogen could actually trick the brain into releasing more FSH, leading to ovulation. And because Femara's effects wear off so quickly, it doesn't mess with the uterine lining like Clomid does. So Clomid was an accident that helped women conceive, and Femara was intentionally repurposed to become a fertility favorite. Now, in the prior podcast, I did talk about how Femara and Clomid work, but let's break them down next to each other. Clomid is what we call a selective estrogen receptor modulator, called a SERM. And what this means is it binds to estrogen receptors. Now, at some receptors, it may activate them. In other receptors, it may block the real estrogen from binding. And that's actually how it works when it comes to fertility. It binds to the receptors in the pituitary and the hypothalamus, but then the estrogen in your body can't stimulate the receptor. So in some ways, it's kind of blocking it. And by blocking it, it then makes the pituitary think that the estrogen level is low. And then it says, hey, I need to make more estrogen. So it releases more FSH and LH, which then cause your ovaries to grow and to eventually ovulate. But this is the interesting thing about Clomid. Because it is not specific to just one receptor, it goes to all estrogen receptors. Sometimes it will stimulate, sometimes it will not. And so it could be going to, let's say, the breast, it can go to the uterus, and it can even cause your uterine lining to be affected, even causing your cervical mucus to dry up. Whereas at the bone, it's going to work as an agonist and actually help build up bone. So it's not a pure blocker, even though it works that way for fertility. It's like a key that goes into the lock, for many different things, but doesn't always unlock everything. Sometimes it's going to be antagonist, sometimes it's going to be an agonist. But Femara, also known as letrozole, takes a completely different path. The outcomes are the same. Both of them are going to cause FSH and LH to rise. But because it's an aromatase inhibitor, it means it does just one thing. It stops the enzyme aromatase from converting androgens into estrogen. All the estrogen that you have in your body comes from testosterone or some type of androgen. So if you stop the conversion of testosterone to estrogen, then you're going to temporarily lower the estrogen level. And when the brain sees that, now instead of tricking the brain into thinking there's low estrogen, the estrogen level actually did drop, and that causes the pituitary to release more FSH and LH, which then will stimulate your ovaries to make more follicles. Now, once you stop taking Femara, your estrogen levels will return to normal, but the follicles are already growing. And because Femara only lowers estrogen for a short time, it doesn't have that lasting anti-estrogen effect on the uterine lining like Clomid would. It's essentially cleaner, quicker, and for many women, much easier on their body. And we now know it actually benefits women with PCOS even more. So to help clear up this picture, let's take a step back and compare these side by side. Let's talk about mechanism. So for Clomid, we are blocking the estrogen receptors in the brain because we're preventing the real estrogen from going to the receptors. Whereas Femara, also known as letrozole, actually blocks the estrogen production because it stops the enzyme. Now, what about the duration? Well, for Clomid, it's very long. It usually stays active for about 5 to 7 days, whereas Femara is very short, about 2 to 3 days. Now, when it comes to the impact on the lining, as we talked about, Clomid can thin the uterine lining, and it can also dry out the mucus of the cervix, whereas Femara preserves the lining, and it doesn't usually affect the cervical mucus. Now, when it comes to side effects, if you've ever taken Clomid, you know it has a lot of side effects. Hot flashes, mood swings, visual spots actually require you then to stop the medication. Femara doesn't have as many side effects. Some people will get fatigue and some mild headaches because of the drop in the estrogen, but overall, do very well on it. And as I mentioned, people with PCOS do very well on it. So when it comes to the best use case, Clomid can be used in people who maybe are just taking the medication on their own. Think of like timed intercourse cycles on your own. Whereas letrozole, anytime I'm doing IUIs, if I know someone had a thin lining with Clomid, or they have PCOS, or even Clomid-resistant cases, I'm going to put them on Femara. Now the question is, why one over the other with timed intercourse? Well, that's because Clomid is the only FDA-labeled medication for fertility. Femara is not. That is absolutely off-label. It's being repurposed as a fertility drug. And there's actually a teratogenic effect. If you are taking Femara and you're pregnant and you have a female, it is possible that you could androgenize the female to develop a penis. Now, this is more theoretical because, first of all, you don't develop a penis or vagina until you're about 10 weeks in utero. So you would have to really not know you're pregnant while taking that Femara to be able to affect it. Plus, you have to keep continuing taking the Femara to lower the estrogen levels to then reduce the estrogen levels that are exposed to the baby. So in summary, Clomid is the OG fertility pill. It's powerful and effective, but not always as gentle. Femara is the modern alternative. It's subtle, shorter acting, and often a better fit for certain patients. So here's an interesting question. If Femara didn't work at 5 milligrams, why not go to 7.5 or 10 or just keep going up until it finally works, just like with Clomid? And that's a great idea, right? If some works, then more is going to work better. But if you remember, they work indirectly, not directly. Both Clomid and Femara depend on the pituitary gland to release FSH and LH. So there's a point where your pituitary says, hey, that's all the hormone I got. Once it's maxed out, it doesn't matter if you increase the dose of either of them. You can't make more eggs because the pituitary cannot make more hormone. You effectively bled it dry. So what we find is, for Clomid doses over 150 milligrams, it usually doesn't help much, partly because the higher doses can hurt your lining and affect the cervical mucus, but again, you pretty much burn out the pituitary. There's not much more you can get. The same goes with Femara. Usually people don't go above 7.5 milligrams, but I see people go to 10. I've done it myself, and honestly, I don't see much of a difference either. Think of it like pushing the gas pedal on your car. If the engine's already at full speed, pressing harder won't make it go faster. That's the limit of that vehicle. And your pituitary also has a limit. Another common question will come is you take the Clomid, you take the Femara, and you don't get pregnant. So common sense would say, well, if you didn't get pregnant on 5 milligrams of Femara or 100 Clomid, then we should go higher. But not necessarily. If your follicles grew normally, then that means you responded. Not getting pregnant doesn't mean the medication failed. Ovulation is only one step in the process. Remember, you still have to have fertilization, a healthy embryo, implantation. So increasing the doses is not going to fix anything. It's already working. And potentially, as we talked about with Clomid, overstimulating can even cause issues such as drying out the cervical mucus. Now, if you don't respond, yes, you should go up on the dosage or even switch the medication because at that point it's not working. And that takes us into the next category, gonadotropins. When Clomid and Femara don't work and the pituitary is out of hormones, the only way to get it then to work is giving gonadotropins because that is actually injecting FSH directly to the ovaries. Now, when I say directly, yes, it's going through your skin, going to your blood supply to the ovaries, but it's getting there and we're not tricking the pituitary. They skip the brain entirely and go straight to the ovary. And it gives us precise control where we can fine tune it, go up and down on the medication as we need to. Now, there's a downside to this medication. You think, well, why don't we use it on everyone? Well, because it's expensive and it carries a higher risk of things like twins and triplets. Now, at some clinics, we will combine them. We call them min-stims, where we actually use oral meds and injections together. Now, keep in mind, not all clinics do that, so don't be surprised if yours doesn't. Very few do. Matter of fact, there is a big push against going away from gonadotropins because of the multiple cycles. And as a matter of fact, if you have insurance, it's not uncommon nowadays to see insurances not even allow us to use gonadotropins because they're worried about the multiples. They would prefer you to go on the IVF and want you just doing Clomid or Femara by itself. So what are the key takeaways? Well, first, Clomid and Femara both trick the brain into producing more hormones. They just do it differently. 2, gonadotropins bypass the brain and go directly to the ovaries. It's not indirect, but direct. Number 3, higher doses don't always mean higher success. They can mean higher side effects, which nobody wants. And number 4, the goal is quality ovulation, not quantity of medication. So, next time you wonder why your doctor didn't bump your dose, remember, it's not about doing more. It's about doing what's right for your body. And if you ever want to dig deeper into some of these topics, join me on Sperm Meets Egg, where you can come on live and ask your specific questions in real time. As always, I greatly appreciate everyone that listens to this podcast. And if you love us, give us a 5-star review on your favorite medium. And if you know someone who hasn't heard us, tell them about us. If you have an idea for an episode, please send it to me at tbft@newdirectionfertility.com. I'll be more than happy to do an episode on that. Until next time, keep learning, keep laughing, and keep tacoing about fertility. I look forward to talking again next week on Taco Bout Fertility Tuesday.